My section here is to talk about post-traumatic stress disorder. And I'm going to talk about it for 20 minutes. And in that period of time, I'm also going to try to talk about one of the two main ways in which post-traumatic stress disorder is treated successfully. This isn't enough time to talk about these things. We could be here from now till midnight, but I wanted to just give some kind of highlights of some things to know about PTSD and some of the ways that it could be treated. And I think fortunately, probably most of you already know quite a bit about what this condition is. The PTSD is actually a condition that's been around probably for centuries, probably through all of human experience. It's only been since 1980 that it's been an identified diagnostic category within the diagnostic manual. Before that, we had in the Civil War, it was called war insanity. In World War I, it was called shell shock because the assumption was that people their thinking processes were somehow blocked or interrupted by being close to exploding shells. And we now know that that isn't exactly what's going on with PTSD. That's more in the category of traumatic brain injury. World War II, it was called combat neurosis. In the 1970s, it was called post-Vietnam stress syndrome. And then PTSD is a term we've used since 1980. Initially, it was thought to be an untreatable disorder. And you still see this sometimes on TV. Someone on CNN will step up to a microphone after a natural disaster, and there's lots of people that have been traumatized and injured, and the person will say, "These poor people will never get over this." This is something that is still part of our culture to think this. This is a myth. This is not true. PTSD is a very treatable condition. The other thing we also hear sometimes is another myth about PTSD, that if people just put their mind to it, they'd get over it. Oftentimes people who have this condition, after a while, other people in their life start saying, well, isn't it time to just forget about it and put it in the past and not let it bother you anymore? It'd be nice if that were possible, but for certain reasons that I'm going to try to explain here, that is not something that is easy to do for people who have this condition. Basically, these ovals here are meant to represent, I'm going to use this in showing this to you as a way of representing the condition of PTSD. Think of the green area here as a person's entire mental life, their conscious life, all the things about their world and about themselves that they know. And the red here represents a memory of a traumatic event, a terrible traumatic event that was so over the top, so difficult for that person, they weren't able to understand it at the time or incorporate it into their usual ways of thinking about things. And when this condition happens, the traumatic event flashes in the mind. So basically, this is what happens. The memory comes flooding into the person's awareness, and it's basically a dysfunction of what is the normal ways in which we all process information about events of life, including disturbing events of life. Usually if someone has something happen that is disturbing in their life, they process that in a way that doesn't involve therapy. Like, for example, let's say on the way home tonight, you pass an accident on the highway, and it's really awful. It's a terrible accident. It's all being taken care of. There's police there. There's an ambulance there. You're waved on through. But it wouldn't be surprising that 10 minutes later, you might have flashing pictures in your mind of what you saw, if you saw some gruesome things. And you might even talk about it when you get home that night. You might have a dream about it that night. When this happens, something occurs with the memory of that event, which is that it becomes less disturbing. A person might then wake up the next morning, think about the accident again, maybe think about it when they drive by that place. But a week later, it's likely to be something that's very small in their mind, something that isn't really it doesn't have the flashing impact. The picture might have faded, the feelings about it might be faded, and this is the natural thing that happens for all of us when we process disturbing information. There's an event, but adaptive learning might take place. The person might say, well, I'm going to drive more carefully along this section of highway. Now, that's how the brain works normally when a person is responding to events that are initially disturbing. However, we all know there's such a thing as trauma. Trauma we can be defined in many different ways, but one way to define it is when a person has an experience that is outside their normal ways of functioning. They don't know how to, the brain doesn't know how to incorporate what happens. It doesn't fit into their narrative of life, about themselves, about who they are as a human being. And the information processing system, in a sense, fails. And what that reliably results in is two separate states of mind that are simultaneously present within the individual. The person now still, let's say a person escapes from a burning house, and for a brief period of seconds they have a sense of, I'm about to die. I'm going to die right here. But then they get out. The next day they might wake up and everything in their life is the same. If other people got out of the house too, the house is gone, but they have the same job, the same car. But now there's this memory of what happened. And let's do the next one. They may have a re-experiencing that happens when they think about it. When they start to think about it, they get flashing pictures in their mind. They're filled with terror once again. They may have avoidance of going back into the area where the house fire occurred, or avoidance of other reminders of it. There may be a sense of hyperarousal, which basically means their sympathetic arousal is hyperactive. It comes on very strongly for the person. And in addition, they're likely to have cognitive distortions. In other words, a person who goes through this type of experience, who has a traumatic memory, is going to have distortions cognitively. The person might think back to something that happened many years ago and think, that just proves I'm a worthless person, or I'm incapable of doing things for myself, or I'm a bad person, or that when I think about that again, it's like I'm experiencing terror all over again, like I'm in danger. These are cognitive distortions that are occurring. And PTSD, they say that time heals, but it doesn't always work that way. Sometimes time does heal, but for other people who have this condition, it remains alive and active. I've worked with veterans from World War II that came into my office for therapy 60 years after their traumatic experience, and they still were having the nightmares. And so it doesn't always heal this way. Fortunately, we have some treatment methods that help the healing process along. Could we get to the next? Okay. If there's a reminder of the trauma, this is how it feels to the person. If the person has, for example, a house fire that is stored as a traumatic memory, they might smell smoke in the air 5 years later. Okay, the next slide. So, talking therapy, traditional psychotherapy is helpful for PTSD, but it's marginally helpful. It isn't nearly as helpful as some newer methods that have been developed. And the two main methods that I'm going to be talking about here are eye movement desensitization and reprocessing, which is abbreviated as EMDR, and cognitive behavior therapy, which involves prolonged exposure and cognitive restructuring. These are the two methods of therapy which have been endorsed by a number of organizations. This is just a partial list of national health organizations. I think every European country now has endorsed, through their national health organizations, has endorsed these two particular methods as treatments for PTSD. So traumatic memories result from a failure of the natural information processing system of the brain. The traumatic memory itself is a reliving. It's not really a memory. The purpose of therapy is to turn it into what we can call a normal memory. A normal memory doesn't come flooding into your mind in a very unwelcome way and flashing with pictures. It's just a memory of something that happened. You might remember something from last summer. You might remember where you parked your car today, and it'll be that memory will be there for you when you leave here today. Normal memories have a certain feeling of they just come up when you need them. Traumatic memories tend to come in a very unwelcome way when they are triggered by some particular reminder in the present. And here's an example of a person who was traumatized, who was sexually assaulted in college 18 years prior to coming into therapy. And in that time, she has gone into groups where she's talked about what happened. She's read some books for survivors. She knows that she is safe with her therapist. However, what this client reports is that when she goes home and she's with her loving partner who is a safe person, and that person touches in a certain way that is a reminder of the traumatic event, she has this whole package of unprocessed re-experiencing of the traumatic memory. And you might say, well, this is all going on in the same brain. This is this whole enterprise today is about invisible disabilities, and the person wants to be seen as a person who is normal and who is able to function normally, but what comes into the mind and spoils good times is this unprocessed traumatic memory. And that creates, and that is unable to connect with safety and knowledge about the present that is in that person's understanding. It just doesn't connect. Why doesn't it connect? There's a kind of a neurological barrier to this. And PTSD is the one diagnostic category, the one disorder that's listed in the diagnostic manual for which we have now a pretty good understanding of what's going on neurologically with it. PTSD is a hyperactivation of the three areas within the red circle up there, the hippocampus, the amygdala, the insula. These are all parts of the brain that are in the center of the brain that regulate emotion and process memory material. And what is relatively weak in a person who is having a PTSD flashback is activation of the frontal lobes, particularly those areas that are listed there, including Broca's area, which is where language is. So that a person who's having a PTSD flashback is having a reliving experience in a state of speechless terror. They're unable sometimes to even find the words to tell what's happening. So this is something that is, the material on the right cannot connect with the material on the left because it's been blocked and there's certain ways in which this blockage occurs. So the memory of a trauma is not just a distortion in recall. It's a distortion of perception in the present and prediction of the future. A person who has this particular issue will sometimes see events in the present through the filter of their traumatic past. If a person has been sexually abused in the past, they might see new people in their life as potential assailants. A person who's been in a terrible auto accident, and maybe they were rear-ended in an intersection. And that person if they have PTSD after that accident, they may be looking in their rearview mirror way too much. I had one client that came in after 2 accidents. She had been rear-ended, and then she had a second accident where she drove into the drive-up window of her bank because she was looking in the rearview mirror too much. So this is something that can happen. And PTSD also distorts a person's expectations regarding the future. So cognitive behavior therapy, one of the 2 methods, this is how it works. It takes a situation like this, and at first there is emphasis on increasing the person's present orientation and being able to have a sense of being safe in the therapist's office, safe in their life, so that they begin to have a sense of, I'm bigger than this traumatic memory. And then, through different types of discussion that go back and forth, and different types of discussion, particularly about what is logical to think and what is not logical to think, a person develops a new cognitive understanding of the traumatic event. Like a person might come in and say, it's really my fault that happened. It's my fault. Well, it wasn't their fault. they're blaming themselves because that's part of their PTSD. And a new cognitive understanding might be to get to a point of being able to say, I realize now that it wasn't my fault what happened. I did the best I could. So the new cognitive understanding is developed through just discussion with the therapist. And in that way, then, the traumatic material, the underlying traumatic material, becomes less and less and becomes something that then is healed in the process. That's basically how cognitive therapy works. It involves, and its research has established that it's a bona fide method of therapy. The research indicates that for a single incident of adult onset PTSD, something on the order of 12 to 20 sessions is usual. And part of that is that a person is given the instruction of making an audio recording of the traumatic event and listening to it every day on a daily basis. So that's that particular method. The method that I tend to use more often, actually, I've been trained in cognitive therapy, but EMDR is the method that I prefer. I teach EMDR. I've taught it in Europe and in Asia and in the United States, and I've been using it since 1992 and in my practice. And this is the way EMDR works. You start with the same type of basic situation with PTSD, and in various ways, you increase the person's sense of safety in the office, but this is just in preparation for the actual traumatic processing. And then the next step here is to make sure the person is able to stay in what we can call dual attention. In other words, that a person is able to be simultaneously aware of the safety of the therapist's office while accessing the traumatic memory, which for some people that's easy to do. For some other people who have PTSD, that's very difficult. So the time for preparation varies from person to person. But when that's established, then the person is asked to think of the traumatic event, hold it in mind. They're asked certain questions about what they're experiencing while they're looking at that in their mind, and then engage in focused sets of bilateral stimulation, which means the person is asked, can you think of that thing that happened, that awful house fire? Get a picture in your mind of the worst part. Notice what you feel in your body right now when you think of that. Notice where the sensations are. Notice that thought in your mind, I'm about to die, even though you know you're safe here now. But that thought is still there and very powerful. And follow my fingers for a set of eye movements, or in some cases it isn't eye movements. Sometimes it's alternating stimulation of other kinds, taps on the hands that go back and forth, or auditory tones that go back and forth in the ears. But there's some type of right-left stimulation that goes on for a period of about 10 or 15 seconds. And then the person is asked to stop and report whatever they're experiencing at that moment. And then the therapist proceeds with either continue on with another set of eye movements, or they're given some other type of instruction so that the processing can continue on. And I'm making it more simple than it is, but when that occurs, what happens is that the negative material, the unpleasant memory, simply becomes a normal memory. The disturbance goes away, and what occurs is the resolution of the memory, an integration of the event into the person's life story, as well as increased self-esteem. And all these things are measured numerically in the EMDR process. Now, I just explained how it happens, and it happens pretty quickly. And when I first heard about EMDR, I was not convinced. I was pretty skeptical. And I quickly was able to see that it works very nicely, and that's why it's now validated by all these international organizations. Sometimes people will say that they don't really think it can help. There are still critics of EMDR out there, and I think it's because, frankly, EMDR is goofy. It's something that when you talk about getting over PTSD by watching some therapist go like this in front of you, and somehow that's supposed to help, that's something that's very hard for people to swallow. And it's very common for people to say, I'll try it, I guess. You seem like a competent therapist, but I don't expect it's going to work. It's not necessary for the client to believe in it at all. That's not necessary at all. It's not one of these things that if you don't believe in it, it doesn't work. It works or it doesn't work. And it doesn't really have much to do with whether the person is convinced in the beginning. What I usually say to people when we're in describing it before we actually begin using EMDR is, we'll know after we start within about 10 or 15 minutes whether this is helpful to you. And you'll know before I do. And that's true. So that's just part of the features of it. Generally, people that are skeptical of EMDR, in my experience, have not been people who have witnessed a video session or witnessed it in person or been a recipient of it, because it does sound very strange. So I just wanted to say that because I think it's an important aspect in understanding what EMDR is. So let me quickly go through a little more of the complexity of this method. I won't dwell on any of this. I'm just going to list out the 8 phases of therapy for a single incident traumatic event. History taking, getting to know the client, getting comfortable with the situation, explaining the situation to a client, and then explaining what EMDR involves so they know what they're getting into. Stabilization means simply that helping a person really develop the ability, if they don't already have it, to stay aware of their surroundings in the therapist's office while they're beginning to think about the awful things or awful thing that has happened. The next step is assessment of this particular target memory, where the therapist asks the client to identify a visual image of the worst part, a negative cognition about the self that goes with that, like I'm about to die, or I'm worthless, or I'm responsible for a horrible thing that happened, or something like that. There's usually a negative thought about self that's connected with the traumatic event. Also, the emotions, the body sensations that go with that. Those are all identified, and then the person is asked to hold all these things in mind and go through sets of bilateral stimulation back and forth, and which is pretty interesting how that works, because what occurs then, very reliably, not always in one session, but usually over the course of a few sessions, is that the disturbance about the memory, the emotional disturbance, goes to 0. That's the typical result. When that occurs, a person is helped to replace the negative cognition about self with something that is more reality-oriented and more positive with reference to the event. If there are still some remaining sensations in the body, just as a residue of the trauma, those are dealt with in particular ways. And then the next time the session is closed, so the person, in a way that the person doesn't leave the office, still stuck in a traumatic flashback. That is not something that should occur. And the next week when they come in, the person is just simply asked how it is for you this week, how'd it go after our session. So those are the phases of EMDR therapy, and a lot could be said about all of them. Bilateral stimulation is the hallmark of EMDR that sets it apart from other methods of therapy. And in the back of if you got a handout, I think with this, that lists out different research that's been done on the what? A download, okay, good. And it basically, this is just some research that shows how eye movements particularly have an effect on a person's experience when they're holding in mind a certain emotionally charged memory. Basically, all this can be sort of summarized as when a person engages in eye movements, sets of eye movements, while thinking of an emotionally charged memory, several things happen. One is sympathetic arousal is lowered. Some studies are pretty clear about that. Another thing that happens is the associations to that event expand, so that more and more information, more and more knowledge comes into the mind, and often that is very helpful for the person because they're able to see it in a larger context. And so most EMDR therapists have many, many clients where they've seen this occur. I wanted to show, I thought about showing a video of this, and most of the videos I have are people who've given permission for me to show a video of a session to other therapists who are EMDR trained, so I didn't feel it was appropriate here. But I did want to show some results of some research, and there are There are currently 27 published, peer-reviewed, randomized studies that show EMDR is very effective relative both to control groups, no treatment control groups, and to other methods of therapy. Generally it shows an equivalence with cognitive therapy, cognitive behavior therapy, but EMDR is in some ways preferable to me because it doesn't require homework. And the standardized, empirically validated method of cognitive behavior therapy does require homework that a person engages in, and clients are not always thrilled about having to go home and listen to the audio tape of their trauma. So, and this is a study that we did in Turkey several years ago after a huge earthquake that happened near Istanbul. In the course of about 10 minutes, if you can imagine this, about 25,000 people died south of Istanbul along the Sea of Marmara. And after that, many people were displaced. They had seen death, they'd seen destruction, horrible things occurred, and they were displaced and living in tent cities. The tents were supplied by the U.S. Marine Corps, actually, that were in surplus, and they just set up these huge communities that would go for miles and miles where people were living in tents. And in the tent cities, members of the Turkish Psychological Association, Turkish therapists, set up clinics and went out to the tent cities to try to help people. And what they found was that, these people were traumatized, but they also were not used to any of the conditions of psychotherapy. The methods of taking homework home and listening to an audio of your own trauma and that kind of thing was not acceptable, and people just didn't want to do it. And so they were looking for other methods of treatment. And so a friend of mine who is a Turkish therapist called me and asked if we'd come over and set up a training program for Turkish therapists. And we did that. And over the course of about 4 or 5 years, we trained about 800 therapists in Turkey in this method. And there ended up being probably close to 30 or 40,000 people now that have been treated for PTSD in Turkey following this earthquake. But this is some data that we gathered very carefully after this earthquake occurred of a small select group of people, 41 people that were coming into the tent city clinics. And this show, I don't know if you can see the bar graph here, but over far to the left is the scores before therapy for people, and then after therapy, and then follow-up. The total scores for a PTSD measure, and then the other bar graphs going over towards the right are measures of the three main components of PTSD, the re-experiencing components, in other words, nightmares, flashbacks, visual images that keep coming into the mind, avoidance of reminders, avoidance of thoughts, avoidance of places that bring up the flashback, and the arousal level, in other words, how much anxiety the people had. And you can see that in all these measures, there was a significant change from before therapy to after therapy, and at 6 months follow-up, those changes continued. The average number of sessions for this result was 5.1 sessions. And the range was 2 sessions to 12 sessions. In other words, the person who needed the most sessions, it was 12. The person who needed the least session was 2. The average was 5.1. In this study, many people came in suffering from PTSD, and they were already on medicine. The main medicine that people had was SSRI antidepressants. And so we divided up. We didn't ask anyone to stop their medicine because it was that kind of situation. We didn't want to have any, it wasn't a research project. We were just trying to do a naturalistic study of this project to help the survivors. But the bars to the left there show the amount of PTSD in people both on and off the medicine. The lighter blue is without medicine, and the kind of maroon color is the pre-score with medicine. after this 5.1 average sessions, you can see down below how much reduction in PTSD there was. And then the follow-up was 6 months later. And it's interesting here, look at that salmon-colored box there. Those are the people, that was the 6-month follow-up for people who had come into this project, this research study, on a SSRI. Most of them were on Zoloft. And all but one of those people had spontaneously just gotten off their Zoloft in that 6-month period. So that's an interesting thing. So there are many studies like this. I just wanted to show this one because it was one that I happened to be involved in. So we're talking here about, everything I'm saying here has to do with single incident trauma leading to single incident PTSD. But for many people, especially people who come to therapy, they don't just come in with single incident PTSD. This would be true for combat veterans. This would be true for many people who grow up in dysfunctional family situations. And one thing there's been some excellent research on how a difficult childhood in various ways, and these are characteristics you could say are part of a difficult childhood, lead directly to certain types of problems in an adult life. There's a very strong, significant correlation between the accumulation of different events on the left there and how it contributes to the particular problems that are on the right, including longevity. But all the physical diseases as well as addictive disorders and mental disorders. And what this means, I think, is that traumatic experience is actually very strongly implicated in every mental disorder. Traumatic experience really sets in motion many different disorders. Now, that's not to say that there aren't other issues, too, that have to do with a person's dysfunctional neurology that's separate from their life experience. People say, well, schizophrenia, bipolar disorder, things like this are problems that basically have to do with something not functioning correctly in the brain. But even in those situations, we have histories of abuse and neglect. And this is just one study that shows this. For schizophrenia, for example, when the histories of people with schizophrenia are examined, 46% of those people have clear traumatic events from the past: physical abuse, psychological abuse, sexual abuse, or witnessing domestic violence in their families. Bipolar disorder, 50% of those people have experienced some type of prior trauma. 40% of the people with schizoaffective disorder. So, in other words, trauma is implicated in all these conditions. And here are some ways. I'm an advocate of EMDR. Some people have accused me of being kind of a fanatic about it. It's partly because I struggled for so long in trying to find other ways of dealing with the most difficult part of presentation of someone who had had a really difficult life. People would often come into therapy, and in therapy they would learn, they'd gain insight into why they were still feeling bad about themselves, or ashamed, or feeling inferior, or feeling depressed. But the hardest part always was the feelings of it. The person might understand fully why they felt bad, but they still felt bad. And when I discovered EMDR in 1992, I was very happy because it really filled in that particular gap in my arsenal of therapeutic tools with people. So here's just some research that in each of these areas, and this is all in the handout that you will have available if you want to find these references. But each of these areas is something that is, it's been established that EMDR methods focusing on memories that are associated with a particular problem of that particular individual is extremely helpful in resolving these particular problems, including some things that even today are thought to be intractable. For example, pedophilia, I think, is generally regarded as an intractable disorder, but there's been some excellent research with people who have had this problem where they are able to not only tell the world that they're over it and they no longer have arousal for children, but also it's tested in other ways physiologically with the penile plethysmograph and things like this, so that they really demonstrate that they no longer have that arousal. So, and phantom limb pain is another issue that has been regarded by many people as intractable, but is responsive to EMDR. So many people come to therapy not just with one trauma, but with many. And this is especially true, I think, with people coming back from the wars that we've had, where it isn't just one thing that's happened sometimes, but many events that were just piled on, or maybe a daily type of traumatic situation. When that occurs, oftentimes a person will learn ways of protecting themselves from the full emergence of all these traumatic memories by having what we can call psychological defense. Now, I'm not saying defense here is something that, we think of defensive people as that's kind of a negative thing. That's sort of a criticism of someone to call them defensive. I'm talking about defense here as ways a person learns to protect themselves from being overwhelmed by being flooded by their traumatic memories. One way is denial, just simply to sort of get yourself into a state of mind where it didn't happen. Or avoidance, I'm not going to think about it, or I'm not going to talk about it. Or if a person has something that keeps coming up that gives them a lot of fear, sometimes that can be covered by excessive anger or by addictive disorders. There are many different types of defenses that come up. I'm just mentioning it here to point out that it isn't just a matter of simple processing of a particular traumatic event sometimes. Therapy sometimes can be more complicated. We can think of 3 different ways that dysfunctional life experience influences the development of personality structure. Many people come into therapy with a situation like that one, the second group of ovals there, where they have lots and lots of traumatic memory material that's unprocessed. And for those people to form a defense blocks the emergence of all that traumatic material. So it can be a defense of avoidance, it can be a defense of idealization. Sometimes a person will come into therapy and say, one person came in and said to me, as I was just gathering background, I said, tell me about your family. And she said, well, my dad was the best dad in the world. And she really said it with a lot of positive feeling. It turned out later that she had totally dissociated some very bad things that father had done to both her and her sister. And so that can happen sometimes. And shame can be a defense. This is a very common defense of children who are abused by a caretaker at an early age. A child who's abused by a caretaker has an awful choice. And many children will not choose consciously, but just kind of gravitate towards, I'm a bad kid with a good parent. And it kind of makes sense, even though it may not be accurate, because that way the child still has something that is essential to every child, which is they still have a good parent, at least in their own mind they do. And also the child can regain a sense of control in that way, maybe after a horribly out of control trauma situation, by saying, well, maybe if I just tried harder to be perfect, maybe my parent would treat me better now. So shame can be a defense also. And the situation below is something that we see sometimes with people who have a dissociative personality structure, not just multiple personality or dissociative identity disorder, but also other types of lack of access between different self states that can happen if a person initially is neglected at an early age and then later undergoes traumatic experiences. And oftentimes a person will come into therapy without a full awareness of all the traumas of their life. There can be a lack of access between this part of the personality that is tuned into being normal and the part of the personality that holds traumatic experience. And this is very relevant for a conference about invisible disabilities, because oftentimes the apparently normal part of the personality will be the part that the world sees. the turmoil will be very private, very lonely for the individual. So, and actually this is an area that I've written about, and how to treat this more complex type of problem, but there are ways to do that using EMDR plus some other methods too. So basically, at the end of therapy, what we can find with people is an absence of the intrusions of the trauma material, an absence of the feelings of fear and hopelessness and anger and shame and negative thoughts about self and the physical sensations. And the person will be able to think back on the event, and it will be like, yeah, that happened, and it's over now, and it's kind of taking its place in my memories. It's not something that tears me up anymore. Increased self-esteem is also part of that, and a clear realization of that was then, this is now. And that's, and oftentimes if a person initially has a different sense of self that is presenting normally to the world, and another sense of self that is hidden and secret and shameful, there will be a unification of those different states of mind.